Hello everyone, today I'll be presenting a concise 3-case series on placenta accreta spectrum with emphasis on multimodality imaging using ultrasound, Doppler and MRI. These cases highlight different severities of placenta accreta spectrum and demonstrate how imaging findings directly influence management decisions. Placenta accreta spectrum includes accreta, increta and percreta, classified based on depth of placental invasion into the myometrium and beyond. The incidence is rising mainly due to increase in cesarean deliveries. Ultrasound remains the first line modality for diagnosing. Doppler helps in detecting abnormal vascularity, and MRI serves as a problem solving tool for assessing the depth of invasion, evaluating posterior placenta, and identifying the involvement of adjacent organs. Early and accurate diagnosis plays a key role in reducing maternal morbidity and mortality. We conducted a retrospective analysis of 3 antenatal cases that were diagnosed with placenta accreta spectrum. All 3 patients underwent detailed ultrasound examination with color Doppler followed by MRI pelvis for confirmation. We specifically evaluated placental site, myometrial thickness, utrovesical interface and vascular patterns. The imaging findings were then correlated with clinical presentation, intraoperative observation and postoperative outcomes. This multimodality and multidisciplinary approach allowed us to accurately assess both the depth and extent of placental invasion. Our first case is a 26-year-old patient with G3P1A1 and previous LSCS. Ultrasound at 25 weeks showed central placenta previa with multiple placental lacunae, loss of lateroplacental clear zone and significant bridging vessels. At 29 to 30 weeks, vasa previa and oligohydramnios were noted, along with reversal of the ductus venosus A wave indicating fetal compromise. MRI confirmed complete myometrial thinning and a placental bulge extending beyond the uterine contour along the right anterolateral wall, consistent with placenta percreta. She underwent emergency classical LSCS and the placenta was left in situ. The baby was delivered at 1.18 kilograms. The image demonstrates a classic high-grade placenta accreta feature. Here we see multiple placental lacunae creating the characteristic moth-eaten appearance. On color Doppler, it showed extensive bridging vessels and turbulent hypervascularity at the retrovesical interface, highly suggestive of invasive placentation. These signs strongly predicted placenta percreta even before MRI confirmation. On MRI, the heterogeneous placenta with complete loss of the myometrial interface is clearly visible. The sagittal T2 images show a focal placental bulge beyond the serosa, one of the most reliable MRI marker of placenta percreta. The coronal section highlights obliteration of the normal uterine contour. These findings helped anticipate a difficult surgery and postpartum hemorrhage. Case 2 involves a 29-year-old G3P1A1 with prior LSCS. Ultrasound at 32 to 33 weeks showed central placenta previa with a large venous lake and prominent tortuous vessels extending toward the cervix and bladder base, raising concern for arteriovenous malformation versus invasive placentation. However, MRI confirmed placenta percreta involving both the anterior and posterior lower uterine segment with loss of the bladder flat plane and multiple vascular flow voids. Because of the hemorrhage risk, she underwent internal iliac artery catheterization as a part of preoperative plan. The grayscale ultrasound demonstrates abnormal placental heterogeneity with deep serosal invasion. Color Doppler shows very prominent abnormal vessels in the lower uterine segment and near the bladder base. The large venous lake and chaotic vascular patterns are highly suspicious of percreta. The MRI images demonstrate extensive flow voids, blood degradation areas, and clear myometrial interruption. The utrovesical fat plane is poorly preserved and the bladder surface shows indentation, again suggestive of high-grade invasion. MRI played a key role in differentiating PAS from a true arteriovenous malformation and in confirming bilateral lower segment involvement. Case 3 is a G4P1L1A2 patient at 37 weeks with history of prior LSCS and a previously documented uterine AV malformation. Her ultrasound showed a normally grown fetus with normal amniotic fluid and Doppler evaluation without placenta previa. MRI demonstrated anterior PAS with focal loss of retroplacental T2 dark line, myometrial thinning, T2 dark intraplacental blands, and placental infarcts. There was no serosal breach, no bladder involvement, and invasion was limited to the S1 upper segment sector. This represents a more limited form of PAS compared with the first 2 cases. There is a loss of retroplacental line and myometrial thinning seen on the sagittal T2 image, with patchy diffusion restriction representing placental infarcts on diffusion weighted images and T2 dark bands with intact bladder wall as seen on the axial. In case 1, imaging demonstrated placenta percreta with clear serosal bulge and early extrauterine extension. Case 2 showed placenta percreta involving the anterior and posterior lower uterine segment with indentation of the bladder wall. Case 3 had a focal anterior accreta limited to the upper segment with no bladder or cervical invasion. On comparison, ultrasound effectively identified the abnormal vascularity and placental lacunae, while MRI provided superior visualization of the myometrial disruption and lateral extension. This highlights both the complementary role of both modalities and in diagnosing PAS. Placenta accreta spectrum results from abnormal trophoblastic invasion through a deficient decidua basalis, most commonly at prior caesarean scar sites. The main risk factor include previous C-section, placenta previa, uterine curettage, and increasing maternal age. Ultrasound with color Doppler remains a first-line screening tool identifying features such as loss of lateroplacental clear zone, presence of placental lacunae or bridging vessels, and thinning of myometrium. MRI complements ultrasound by providing better delineation of invasion depth, posterior placenta involvement, and adjacent organ relationships, particularly useful for surgical planning. Early and accurate diagnosis enables multidisciplinary preparation, optimizing maternal and fetal outcomes, and minimizing intraoperative. To conclude, these three cases demonstrate the spectrum of PAS severity, from limited anterior accreta to complete percreta with extrauterine extension risk. Ultrasound remains the cornerstone of screening, with findings such as lacunae, bridging vessel, utrovesical hypervascularity, and loss of the clear zone being highly predictive. MRI is invaluable for confirming myometrial invasion, mapping the extent of the disease, and identifying the involvement of adjacent structures. Early diagnosis enables multidisciplinary planning, appropriate blood product preparation, and safer surgical management. Our findings align with existing literature, particularly studies by Gynaec and Silver, which describe the pathophysiology and imaging diagnosis of PAS. We also refer to work by D'Antonio and colleagues on prenatal management strategies, as well as the SMFM Consult guidelines on standardized evaluation and reporting. These references reinforce the importance of an integrated imaging approach using both ultrasound and MRI for accurate diagnosis and safe